Move for approval.
Second.
Move for approval by Trent, second by Steve Montgomery. All those in favor signify by saying aye.
Aye.
Those by nay. Oh, nay. Okay. We have a short agenda today, so I probably won't keep you here as long as I did last time. I knew Zim was worried about that. Okay, so Dr. Duncan, you want to come up and cover the annual incentive plan proposals for 2020?
So before I get started with presenting the annual incentive plan and the LTIP plan, first of all, I want to thank members of the board who spent a considerable amount of time, almost a full day, with members of the executive team, those executives that oversee the 5 pillars. Chair Ms. DeBose and Chair of Finance, Mr. Montgomery, and Dr. Weber spent a half a day with the executives who came in one at a time to present the goal and how they set the metric. There was great discussion that went on. The executive team was well prepared, and I have to say the board members were were also very much prepared. Ms. DeBose really came with a lot of questions, challenged the team, and we came to some great consensus as to how the metric should be set, but more importantly, the why behind the goal. And I think this is often where we lose sight around goals. The importance of goals is really to drive a better patient care for our patients and to do it in the right way. And so I just want to give thanks to the 3 board members who spent the time with us. So with that said, I'm going to present at a high level. I'm going to start with quality. You will see each of the executive sponsors of the pillar approach the table in case there are questions. Our first one, as I said, is our PSI 90. Just to remind the board, this is a patient safety indicator. It is a weighted average of observed to expected for 10 safety indicators. The weights of each indicator is based on the volume of that safety event and the harm associated with that safety event. Last year, under the leadership of Dr. Stevenson, who I have here by my side, and Dr. Hochberg, we did quite well at 0.91. There was a lot of discussion at the last board meeting and also at the session that we had with Ms. DeBose. And we feel comfortable in presenting to the board the threshold, target, and stretch as presented here, our threshold of 1.0, our target of 0.95. The stretch, as you recall, the last time was at 0.88, and Ms. DeBose asked that we push that stretch out to 0.85.
Okay. Are there any questions on that one?
Go ahead.
I want to reel myself in to make sure I understand. The stretch is what? What does the stretch? When we,
Okay, the stretch, when we are setting up the matrix, the stretch means that those are high expectations that you want to move toward. Okay?
Your wildest imagination.
It's a movement toward getting better, okay?
So Reverend Emerson, Reverend Emerson, as you recall, the board has asked us to be consistent in how we set these metrics. And so the threshold, we say, is 90% of the time we can reach threshold. 50% of the time we can hit target, and only about 10% of the time can we hit stretch. By moving that out to 0.85, we probably have taken that percentage to even a lower number than 10%.
Explain again why your threshold is 1 and you're already doing better than that today.
Yeah, so prior to this past fiscal year, we had never had in this measure, we had never had a single year where we had done as well as 1.2. Now, let me back up just a half step and explain what these numbers mean. So based upon the types of patients we're seeing, how ill they are, what comorbid conditions they have, their age, the kinds of services that they're receiving, the PSI 90 measure, which is a measure against self, would anticipate that we would get a 1.0. So that means you're performing as would be expected for what you're seeing. If you're above 1, you're performing less well than expected, and if you're below 1, you're better than expected. So this measure is ultimately a very complex ratio of observed over expected. Okay, so anything under 1 is better than expected. I can't tell you for sure that there is a 90% likelihood of us reaching 1.0, because we've only done it better than 1.0 one time. But from a philosophical standpoint, I don't think that it's acceptable for us as an organization to take any credit for providing care to our patients that's not as good as one would expect based on what we're doing. We only want credit if we're either as good as expected or better. That's the only range we ever want to be in ever again. Now, we've only done it once, so I don't know how easy it will be or not to repeat the feat. But you know, this is not a linear measure. You can't go down to 0. There are situations that are picked up by metrics like this that are perfectly appropriate care. And we talked about one, you know, in our session together a few weeks ago, where, you know, someone shot through the femoral vein. If you fix the femoral vein, if you tie off the femoral vein, you won't get caught for a deep vein thrombosis. You ligated the vein. If you fix the vein, though, the patient won't get a swollen leg, but then the vein will definitely clot later. I mean, it will for sure. I mean, we know it. If you're a trauma surgeon, you know this. So, but then it'll hit us a DVT. But I'm glad we fixed the vein because it's better care for the patient. So you're always going to have a certain number of events that you encounter, some of which are not actually adverse. Okay, it's just the nature of using coding data for a pulled metric. It doesn't get down absolutely to the lowest level, but it is certainly possible, and we proved it last year, to perform better than expected, and we want to keep doing that going forward forever. But you know, if we, you know, have another good year, I could see moving the metrics a little bit lower for the future, but it isn't one of those measures where you can keep going lower and lower and lower and lower, because eventually, you know, there's a certain frequency of stuff that isn't actually adverse that's actually measured by this particular metric. But it does hold us to account for providing care that is at least as good or better than we would expect based on our patient population and the services that we are providing them.
How long ago was it that we hit the 1.2?
So fiscal 18, we were, I think we were at right around 1.2. I think it was 1.2 in fiscal 18, and before that it was higher.
Did we look at what was taking place during that time, or were we able to go back and look at what was taking place at that time to see what maybe those factors that?
We absolutely have, and there are two broad areas. One is that we had to improve care in a whole variety of areas, so we did that. But there were also some opportunities in terms of documentation of comorbid conditions, as well as documentation about some of the events that helped us improve as well. The advantage, you know, to the points, some of the points made in the first meeting, where you saw that case mix index has been on the upswing for some of the, particularly for some of the surgical specialties. A lot of the work here has been capturing more comorbid conditions, so we actually do understand the severity of disease of the patients that we are taking care of better.
There's a lot of factors that go into it, and it really took a lot of team effort to your point, to set up those action plans. We did a lot of the low-hanging fruit last year that I think that helped us move to this 0.91. We now have to really hardwire and sustain the work that we did and continue to move forward with improvements. And so we feel comfortable with the threshold of 1.0. To Dr. Stevenson's point, it is what is expected of us. And our expectation is that we will not be below that we will not be above 1.0 moving forward.
This is last year was our first year we actually measured this. So usually we try to go that next year you'll have a better account. And so I'm thinking one more year, then that would prove that this matrix, which way we should be actually going. Because I do hear what you were saying. And I think a second year that you measure this, then we would be looking at that and saying, okay, you're not going to be able to go back past what your results are. You need to set that as, your threshold. Because I know Zim has mentioned a few things about the optics, but I think on this one, when I looked at it, we went back, talked about it again. This is our first year, so if we go number 2 and then you do better, then we're saying, okay, I know you can't go that other way again, okay? That's kind of how I had to look at this.
So how does this, is there an activity that involves comparing these threshold numbers to a peer group population?
It's tough because, effectively, we do because the benchmark is one. We're comparing to ourselves, but everybody else, but that one number is set by how everybody else performs.
Everybody else being the total population or?
Being other hospitals.
All other hospitals.
Other hospitals. This is a hospital measure.
I think most of those, what we're looking at in this PS1 is in our leapfrog. And so if you are doing well, your leapfrog numbers goes up too. So there are a lot of these overlap. So we are compared to other hospitals because we can see where they are and all of that. So that's our comparative group, and you can pull it out by hospitals in Fort Worth, public hospitals. And so when you read over in the Dallas newspaper that somebody is a B and you are a C, it quickly gets your attention. So that's the other way it ties into that measurement. Okay. Any other discussion on that one? So I agree that we need to go one more year on those to get a better baseline, and then we'll be able to, it'll be a different conversation next year. You agree?
Absolutely.
Yes, we do.
Because we'll start with where we are. We will not, I just kind of think that a rule that we would be looking at is that you are going to be either starting there, your target can never be less than what your results were.
Right.
Okay? That's kind of a rule that I would think that we should give some consideration on in setting some standards that you're saying that if we're going to do with results, and we're not going to go back on results, but your targets can never be less than where you are. That sound reasonable? Okay.
It does.
Well,
Yeah. Zim?
Well, I guess what helps me is if what area we're talking about, if that area is low performing, we start looking at what caused us to be at that low performing position, so we can correct that to bring it up. Okay. But when we perform at the level or above, I don't ever rarely hear what we did to do that. And I just, my thing, and I asked this some time ago, is that I think it would just be healthy if we heard or saw what do we do to get to where we are to achieve that, so that we can either mirror that or apply that throughout the hospital. And it'd be interesting to see what the steps were that got us to that spot. So.
What I would say to that, Reverend, is stay tuned. We have, not for this meeting, but for Quality Committee, we have a lot of very interesting information to share with you in the coming months. And I think that some of those questions will be better answered for you, or at least you'll have more insight to ask those probing questions about how it is that we're actually achieving this. But I was looking at, this is a bit of a aside, but I was looking at some of our core measures data today and just seeing some really remarkable things going on in behavioral health particularly. And, you know, that's something that you're going to want to look at and understand well, because there's some really exciting things going on in that area. So, but this kind of stuff, core measures, benchmark data, that sort of thing is going to come before the Quality Committee on a regular basis in coming months. And I think you'll have some of these questions, have an opportunity to answer some of these questions for yourself, and we'll obviously provide as much insight to that as we can.
Jim?
I understand what Dorothy's saying, and I don't disagree that if you're starting your second year of this kind of a metric, that you probably need to get some more information. But the one up there that really bothers me is the outpatient patient experience, where you've attained 8, your target's 4, and so I would question a little bit whether you've got the right measurement parameters set up, and I would suggest to you might ought to go back and look at those to see why you so well exceeded expectations in that one. The rest of them all seem to be in line, and I kind of don't have a problem with that, but that one just glares at me.
So would you like for us to move on to service and we can have some?
Pardon me?
I said, would you like for us to move, we can move on to service and we can explain the outpatient
Sure.
metric and how that was
I've made
set.
my point,
Any-
my comments, so I'm
Okay.
fine.
No, and I could see looking at that why you would have that
Okay.
question.
All right.
Any other questions around our quality goal and metric?
Okay.
Thank you, Dr. Stevenson.
Okay, come
So
on,
our-
Laura.
Next one is service. And much like our people pillar, we get our recommendations from NRC, which is our vendor. The first one is our HCAPS. There was a CMS change in dimensions. Last year, we had 10 dimensions. This year, there are 9. The pain dimension was removed. Based upon our previous 3 years of performance improvement, NRC has recommended that we move from what we have traditionally measured as national rate of improvement to striving for the top quartile performance, which is greater than the 75th percentile. Again, we use the board's recommendation to look where for our threshold, target, and stretch set. Last year, we did finish at 4. And for next year, for fiscal year 2020, we are recommending threshold of 3, target of 4, and stretch of 6.
Okay. On Zim's question, you did some information that you presented. Do you have that? Can we see that? Maybe that would be a better understanding, because the scores actually changed quite a bit from each of those 10 items that we're looking at. It was 8 of them that we only had to do 0.2.
So that was for the outpatient?
outpatient.
Yeah, for the HCAPS.
So, I don't have a mic, but for the HCAPS dimension, we can move to outpatient if you wish, but if we can finish on inpatient, I think that
I
might help.
really don't have a problem with the HCAP, it's
Okay,
the outpatient one.
Certainly.
Before we move on to the next one, was pain removed because of the opioid crisis? And
Yes.
nothing took its place?
No,
Not today.
We just reduced the scale?
that is correct.
Interesting.
They went from 10 dimensions to 9, and that's nationwide.
Okay. Thanks, that was my only question.
Okay,
Yes.
all right. Okay.
Any other questions on HCAPS? Okay.
Good.
Okay. Sure. So as far as the outpatient survey itself, we utilize the National Industry Standard, which today is no longer the CAPS survey, but is what's a real-time survey tool. So when our patients leave the clinic setting, they are issued a survey that is a 10-question survey. We are measuring the same 10 questions that we measured last year. And that is distributed to the patient within 24 hours after the close of their visit. So again, questions are the same. What we did change was last year was the first full year of this particular survey being used nationally. And so our vendor's recommendation was that we move each question 0.3 points. This year, we're in the second year of this survey, and their recommendation, because it's a new survey and it's difficult to get good benchmarking information early on, much like what you just heard with PSI 90 for us, the recommendation was for us to double the improvement rate, so to go from 0.3 to 0.6 improvement per question. And so that would double the number that we needed to achieve. And then again, to Dr. Duncan's point a few moments ago about hardwiring the work that we've done, that can be very challenging when you have a heavy lift like we did last year. So we moved the needle quite a bit last year, and this year it will be about sustaining that improvement and then additionally doubling the improvement rate that we set for last year's targets.
Are we comfortable with the sample size?
The sample size is actually quite large. We will get about close to 100,000 surveys returned on the outpatient side, so it's huge. Yeah, and that's part of the beauty of it, is it's really fast to return to us, so we can action plan on it really quickly, but it additionally allows us a much larger sample size. And we can actually get individual data for it, so we can actually action plan at the physician or provider level.
Checking a particular survey, what's the highest score that can be achieved?
Per question, you mean? It varies. So again, this is top box performance, but the rating scale is somewhat similar to what you see in the HCAHPS dimensions, but also somewhat more complicated. So for instance, the overall rating of provider is the same, 0 through 10 scale. Top box scores, which actually count, would be anything that's rated a 9 or a 10. Anything below a 9 does not count.
So if I understand, I'll ask you a question. Do you expect that your performance in 2020 will be less than 8? Have you got some question about that 8 figure that tells you that it's probably going to come down?
So every time you make improvements like we did last year that are as large as what we did last year, it becomes more and more difficult to continue to achieve at those levels.
I understand that, but when I see a gap between target and the results of 4 points, I kind of wondered, is the criteria wrong? Did we do something more miraculous? What was it that caused that big a difference? That difference doesn't exist in any other category up there except that one. So my question to you is, did you go back and question, am I measuring correctly? Are my thresholds and targets too low? And because
Do you want to speak to that?
the whole purpose of this is to incentivize our employees to do better work each year, right?
That's right.
So in outpatient, you're kind of telling me there's nothing better they can do.
No, that is, no, definitely not. There is a lot that we can do.
So my point to you, though, is how is it that that line is going to challenge them to do better?
So the first year, as Laura said, was arbitrarily set at 0.3 rate of improvement for each of the questions. That rate may have been a little low, but it was a rate that we had to start with. We had no previous data. It was new metric across the country. And so that was given to us as a recommendation to improve by 0.3 for each of those 10 questions. So we felt that not only did we do a huge amount of work in community health, but that metric may have been set low. We may have already been out of the gate when that metric was set. For next year, based upon how we achieved in some of the questions, we actually achieved greater than 0.3. And so for next year, what we said, that we would no longer look at to continue at 0.3 rate of improvement, that we would double that for ourselves. And that's where our challenge would be in going from 0.3 improvement for each of the questions to 0.6 improvement.
So Karen, somewhat, the first set of goals that you set for last year were somewhat peer-placed and somewhat, we think this is about what we ought to be trying to get, right?
Yeah, after speaking with NRC, what was realistic, given that it's the first year that you're rolling this survey out, what is realistic based on our previous performance? And so for us, that may have been too low of a metric. And
So my question to you is, okay, you're into your second year now. In every category, you're probably pretty close to the right quantitative evaluation, except that one. Why didn't we go change that one? Why are we going to wait for another year? And if it's 12, great. If it's 6, you see what I'm saying? We seem to be locked in on these for a 2-year period, when one of them obviously is, we're way over exceeding even the stretch goal.
yeah, stretch.
But you're right. Yeah, I hear what you're saying. This, I don't think we've kind of gone back on this one. We have changed this matrix every year for the last 3 years. We started out using a matrix and remember we had the 72, I have all the notes here. And on that, we're having a hard time achieving, let me say it, we was having a hard time achieving the inpatient. The outpatient have always done a little bit better on their scores. And then we changed to this new survey. And did anybody see this? Did you share this with anybody but me?
So that actually was in your packet last board meeting, and we can get copies of that, to you.
Yeah, that's okay.
If that would be helpful. It was in your last board packet.
Because I can see that, to go back and with you, Zim, where we have made 8. Even on looking at this, with moving it 3 points or 6 points, I'm sure that that's a low score for outpatient, that their numbers could go up some more.
Well, the horse is dead, I'm not gonna beat it anymore, okay? But
Yeah.
as I said the last time, it's an optics thing. And whenever I'm dealing with employees, I don't want to give them an optic that says, oh, okay, I can kind of relax. I want to keep challenging them. And even if it's a fictitious number, when you've made 8, you don't want to go back to 7, do you? Do you?
Could you put your stretch at 8? I mean, your stretch should be there. I mean, you can't go any higher than 8.
We could put our stretch at, I think where we set our challenge was that it would no longer be 0.3 every year that we were improving, that we needed to move quicker. And so it was doubling that to 0.6. Next year, if we continue to move along, I think it becomes more and more difficult. The more that we move along, the work becomes a little bit more difficult, but we can do it. That we may have to move to a 1.0 rate of achievement or 2.0 rate of achievement. But I have no problem with putting stretch at 8.
Kind of in my previous business, I'll question the staff on things, but in the end, I rely on you and your expertise to do the right thing, and if you say this is where I want to be for right now, then that's great.
Okay.
Okay, but I don't like the optics at all. I think based on what happened, is there should have been some sort of a modifier that was placed in the data so that we could see actual, let's call it budgeted versus actual. Actual actually came out to be very different than what we thought it would be because it was the first time we'd done the survey, so we see this huge gap. So based on what you know now, if you had to sit here today and project what the score would be at the end of this current year, what would you project it to be?
I mean, where would we
Yep.
end up? That's a hard question to answer because we are high achievers in community health and we always go for stretch. So that is really hard to say.
What would you personally say, this was a good year for us versus, man, we could have done better than that?
I always think we can do better than what we've done. I think it was a good year for us. We put a lot of resource and effort behind last year. And that was representative of the hard work that we did, was that 8.
But you don't believe that's a sustainable number?
If we were to keep the rate of improvement at 0.3, I would tell you that that was sustainable. And we would have moved that threshold target and stretch higher. Given that we're saying that we're going to actually double that rate of improvement for next year, we're not going to just keep it going at 0.3 each year, but that we're going to double that next year, we're going to challenge ourselves, then we felt that the threshold target and stretch as set was achievable and reasonable.
So this metric, let me make sure I understand. This metric is not necessarily measuring the patient's scores of the survey. It's measuring how much we improved from the previous year.
That's exactly right.
Terrible metric.
Year over year.
Because when people see that,
Yeah.
they're not assuming that is representative of a level of improvement over the last year. What they're seeing is that's the score versus last year. If I gave you a 6 last year, and this year I gave you a 4, then it was a worse year, right? So that's how most people look
Right.
at a metric like this. In our case, what we're actually being asked to consider is, how much better are we gonna get? Except when we look at how much better we're gonna get, we're not comparing it to the actual, we're comparing it to how much better we got. And that's a misleading
Because the better
number.
you get, the harder it is to get.
That's
better.
right.
Really
And so
is,
you end
yeah.
up with a bad metric. I mean, to me, the optics on it don't look good, and it doesn't reflect reality. I think the metric from an optics standpoint should reflect, it should show people we're doing better. We're doing better every single year. And when I glance at this, especially for the purposes that we're looking at it, I want to be able to say, look, I can defend, infinitely how much better we're doing based on these numbers without having to stop and explain for an hour and a half why that number's
Why
better than it
is,
is.
Yeah.
Right.
And
Would it be better instead of having the number 8? Because what I'm looking at that y'all don't have, it talks about going from 49.5 up to 56.8. They went from, it's 8 of those. One of them, they started out at 36.6, and they ended up doing 41.9. So it makes sense to me that you would be looking at that increase in those numbers versus saying this 3, 4, because it's the optic, you're right, doesn't look good.
The actual, I mean, if I look at the actual,
Yeah,
and I say, okay, I went from 36 to 45, I'm like, well, that's pretty good. I feel pretty good about that. But in this case, I'm looking at 36 to
Right.
45 as being not good at all because it didn't increase it enough from what the metric was started. And I just think it's a really bad way to show it.
Why don't we say this? He said a little bit better than I did what the concern is. Why don't we task you with going back and taking a look at this, and then come back with us with kind of what you think needs to be changed or not changed, but
Okay.
with what comments we've made. I don't like to make decisions in a boardroom for the staff, okay? So
Right.
we'll just challenge you, go back and look at this and come back to us.
okay.
Maybe a different way to illustrate.
That and to really show the work, the hard work
Yeah.
that was done.
And
I
then
agree.
maybe y'all would bring a little bit more information when we come to these sessions, showing it a little bit different.
Well, that's
Because we
probably our
did
fault
have
for not reading our portal last time.
well, I keep my stuff, so, yeah.
Honest about that.
But it is numbers. I mean, we will be dealing with those same numbers, and that might be better than what we had. That's what we started with, Gay. because I remember Roger was saying, when y'all change, let's make sure we can compare apples to apples. And we have it at the top up here, but we don't show it here.
Yeah, we
So I'll
got, we may
agree
be
with
too
you.
smart. We may have gotten
Right,
too smart
okay.
in the way that we illustrate
All right,
this.
okay,
Yeah, it's probably
thank
not
you.
apples to apples here,
Right,
as it looks.
okay.
Yeah. Thank
All
you
right,
for all
thank
of
you.
those comments, and we'll come back with that.
All right.
Our next pillar is people pillar. I have Ms. Walker here with me. We'll start with first-year turnover rate. Reminder to the board that this will be our first year in which we look at the first-year turnover rate. Last year, we looked at overall turnover rate, so this is a new goal and metric for us. Our FY19 result was at 38.67. We feel comfortable with setting our threshold at 32.86, our target at 30.94, and our stretch at 29.01. And a reminder that this metric is set and recommended by national vendor Saratoga. And so there's been conversation with them.
This is all employees,
This is all employees, yes.
no waiting for the N in nursing, for example, being so much higher than the N in administration. I mean, this is just all employees, flat out raw data, overall percentage turnover, right?
Yes.
Yes, so this is all of our employees that are within the first
First year.
year of turnover. So when we think about, just as Dr. Duncan has stated, is that we are benchmarking this against Saratoga data, which benchmarks against other healthcare organizations. So we're looking at that first year. And so we have identified, if we focus on that first year of turnover within the organization, it's going to help drive down the overall voluntary turnover as well.
This is voluntary?
This is first year
voluntary.
turnover, yeah, and
And-
involuntary. It
and
includes both of
involuntary.
those.
Both of them.
Yes, because as an organization, we do need to focus on that involuntary because we need to make sure that we're hiring appropriately. Because for us, per policy, we have that 90-day probationary period, and that's something that we do want to make sure that we're leaning far away from it and getting individuals in that's hired right, and so we can be able to decrease that 90-day turnover as well. So that's important because as an organization, what we have to think about, and these stats come from SHRM and they come from Saratoga as our resources. We spend 2 times salary when we deal with turnover. When it gets to leadership, it's 3 times the salary, and then with executives, it's 4 times the salary. So we are spending millions of dollars a year when we're looking at the high percentage of turnover, and that's something that we do need to get under control. What we're going to be doing, looking at that turnover, when we do our LDIs and focus on LAP, we're going to be putting tools in place for leadership to assist them and help them to think about what we can do to help reduce that turnover.
So Pia, is it fair to assume that if I dramatically reduce my first-year turnover rate, that equates to a significantly less 5-year turnover rate?
I don't want to assume that a 5-year. I would feel more comfortable to say 2-year. Because now with organizations, what they do, they're not projecting far out to the 5-year mark. When you're looking at healthcare organizations, because healthcare is an ever-changing market, now they like to try to focus on that 2-year piece. So I would feel a lot more comfortable to say that we could look at that probably 2 years later to see how that reduction has looked.
And what would you suggest that at the end, using these numbers, what would you suggest that second-year turnover rate might be relative to reductions in this turnover rate?
I think
Is it linear?
it is. I think what we need to look at, again, is thinking about what Saratoga is going to be providing us. And we need to pay close attention to what they're giving us and benchmarking against that number as well. Because we ended the year very high, we set these standards as self over self. And so next year, we truly need to focus on where we end and try to keep pushing harder to focus on what Saratoga is giving us as well.
Okay. Any other questions on that? I have the little Saratoga information up here. I have all your,
Yeah, she
Yeah,
really
'cause
came
there's-
quite prepared. Yeah.
but I was looking at their total turnover, if they're targeted, they're saying you should be is about 13.3, based on this report that I have here. First year, they are saying 16.3, 16.3%, so.
So we have a
We
lot of
do.
Yeah.
opportunities.
We do. We have a
Yes,
lot
do.
of work to do.
We do.
Okay, all right.
We'll go on to employee engagement. Just a reminder again that this metric is set by Press Ganey and is based on our previous performance and is benchmarks against similar hospitals. Our FY19 result was at 4.33, and we have set our threshold at 4.31, target at 4.33, and our stretch at 4.35. Any discussion around that one?
I'm with Zim on that one. I'm thinking the threshold shouldn't be less than our actual achievement. You know, I'm thinking at minimum, the threshold expectation should be what we were able to achieve last year, and then move up from that, and not be satisfied. Potentially meeting threshold and rewarding for going backwards.
Yeah, and I'll let Pia speak to that, but we result out at a very high percentile. And, you know, staying within that percentile, your score may come down just a little bit, but it keeps you within that top percentile. And I think that that's what's really important for us, is to maintain that top percentile. And so this allows us for a little bit of that slippage, but keeps us in that top percentile.
So,
And I would say, Karen, that argument supports my notion that it should be 4.33 threshold and not 4.31. I mean, it all comes down to how much variation we're willing to accept.
Mhm.
But from an optics standpoint, I would like to be able to say, we've achieved this, we can sustain this, and our expectations are going to be to sustain this from now on. Yeah, let's try to get better. If we do get better, this is what better looks like. But I don't, in my mind, it's difficult organizationally to accept the notion that we're okay by dropping this 0.2.
Okay. Okay. I mean, I do understand that, because it's hard for me to go from where you are. You always start from where you are, so.
yes, so to speak on that with employee and provider, so Press Ganey is our vendor that we work with each year. When we receive our scores each year at the end of September, top of October, what occurs, we will ask them what is the recommendation that we need to be benchmarking against. So remember, 2 years ahead, we were top decile. This year, we dropped to the 89th percentile, which is expected to occur within organizations, because top decile with any organization is very difficult to hold. Even if you said, Pia, we need to move it 0.02 is very difficult. Trying to move that needle is hard. And so when we go to Press Ganey, we ask them for the recommendation to give to us, because they see all the organizations, they see all the benchmarking. They give to us what other similar organizations, such as JPS, is doing. And so that's how we arrive at our numbers, because you're going to see slippage with your engagement scores, because the reason why you're going to see slippage is because there's going to be changes in organizations. You have to prepare for that change. You have to make sure that you understand that change management is key in organizations. So when that is said, Press Ganey's given that number to us to say, is not saying that we're accepting to do less, but you've got to be prepared for change. Because remember, when you're doing an engagement survey, it's based on behavior, it's based on what's occurring in that organization at the time, and you have to set your measures to be able to equate to that.
Any other comments?
Provider engagement, again, this metric is set by Press Ganey. I think we will all probably be pleased with this one. Our FY19 result was at 4.02, and we set our threshold above that at 4.08, our target at 4.11, and our stretch at 4.14.
And that represents, that metric represents probably a bigger shift in a 2-year period than any other metric we have in the whole organization. I bet you. Because we used to have numbers that were.
Really?
3, 4,
I
and
know,
5,
I
and
know.
yeah.
Yeah.
So, you know, that, to me, that's a celebration.
too.
Yeah, that really is. No,
We need to recognize it.
yeah, no, totally agree. Any other question around the people pillar?
Okay.
Okay.
If not, we're going to bring it. Sharon will join us for the stewardship, and I will let her run through the two metrics that we are proposing, goal metrics.
Good afternoon. I
Hello.
usually say good morning. Okay. So we have not changed the actual metrics for stewardship. They are the same. There is one thing that I want to make sure that you understand. There's really just one of these metrics that are weighted 10%. For most of our employees and staff, it is the modified cost per adjusted admission. If you participate in our long-term incentive, the hospital operating margin is substituted because the modified cost per admission is one of our long-term metrics. So it's either or here for the majority of our employees. It is going to be the modified cost for admission on the AIP at the full 10% weighting. Now, the weighting has decreased this year, and some of the weightings up top have been modified as well. So I don't know if we've talked about that already, but the weightings have changed from last year. So when we look at the stewardship metrics, these numbers, I'm going to start with the budget. The threshold of the 13,991 is set on our budgeted adjusted admissions as well as our budgeted expenses. Now, from our budgeted expenses, the reason that it's a modified cost is because we remove those physician costs from total expense, because in prior discussions, that would be difficult. Some of the physician contracts and coverage agreements, it would be difficult for a director to actually control those expenses in his or her area. So that's where the modified cost comes from. But the 13,991 is based on the approved budget for 2020. As we develop the target number, we assume that volumes are not going to change, but that we're going to be able to save a full 0.5% of expenses. So that calculates out to about $5.2 million in our expense structure, and $13,910 for the target. This year's stretch is a full percentage point reduction in our budgeted expenses, and that would bring the modified cost per adjusted admission to $13,829. I believe last year when we set our threshold, target, and stretch, threshold was budget. Target was a 0.3% savings and stretch was a 0.5% savings. Now we have budget 0.5 and 1%. So this is a more aggressive stretch target. The hospital operating margin, when we set the target and stretch, is using the same savings assumption of the 0.5% and a full percent of those expenses. So those two numbers are tied together mathematically.
What would the 19 result have been modified to the same multiples that we're using for the new report? Because it would have been higher. Just trying to understand how much higher.
So I think for, if you're asking what this spreadsheet would look like if we were looking at the 19 threshold, target, and stretch, what happened is we moved the stretch to the target performance. Now, in our actual result for 19, we were able to carve out $5.4 million from the budgeted expense number, and we took care of a much higher volume. So we had both a denominator impact that was positive and a numerator impact that was positive.
Which, I like that, that's great. It's a little dangerous when we look at it here, which is not necessarily numerator and denominator. Because when I'm looking at numerator and denominator, it's fair. When I'm not, then it speaks to the fact that, you know, all I gotta do is underdo my budget. You know, in order to move the entire dial for the whole organization and how much money the organization pays out in incentives, all I gotta do is fudge my budget. The city people would never do something like that, but for about 30 years of my life. So where's the protection in that? Because when we use budgeted numbers, and then we had this conversation even earlier today on looking at some of our performance metrics on, you know, on the finance report is, what is the real relativity of the budget versus actual? Because if we continually under budget and overachieve, it doesn't point to a good story
So
financially.
let me answer maybe about 3 questions.
Sorry, I actually about to say-
That's okay. And I'm gonna try to hit those, and then you can tell me if I hit them or not. So the budget process is a very difficult process. You know, people always ask me, oh, this must be a busy time for you. No, my busy time is not year end. It's not metric setting. It is preparing that budget. We work very closely with operations to make sure that we have the best budget that we can have at the time. I think a couple of years ago, what made this metric relevant for us is that our expenses are fairly predictable. We know that we've budgeted X number of days, and we know how many hours per day an inpatient needs in care at different levels: nursing, staff, care partner, registration, billing. So labor is the big question always, because it's over half of our expenses.
Right.
But where we have those budget items that have a lot of questions is up on the revenue side. I have always budgeted conservatively on the revenue, because the discussion from this morning, you just don't really know what's going to happen in a future formula setting from HHSC. So we do focus a lot on the costs. There was this year, and it's in the detail, but there was this year a $22 million expense budget for onboarding future projects. And the way that we're going to deal with that here is it's not a cushion, it's a control $22 million from my purview. If we release $5 million of that, or $7 million, we'll do 7 because the math's a little easier. If we release $7 million of that, there's $15 million that were not spent. When we use this evaluation, I'll take the total actual expenses and add back the $15 million that we didn't spend. And that takes away that fluff or cushion or padding. And I will say that, you know, each year I go through this calculation with a fine-tooth comb, and we've had discussions about things that probably needed to be adjusted after the fact, and I'm very forthcoming with you on that. So in my mind, the setting of my budget is done under a high level of scrutiny, and I'm not forward thinking on how can I game this metric on an evaluation.
Oh, I know that's not
So-
your intent. I'm not saying it is, Sharon, at all. It is not nefarious. I'm not presuming that we intentionally undercut our budget, but I am saying that historically, we always perform budgetary-wise less than actual. I mean, we always budget, in other words, and you can look at performance for the last 10 years in this organization, and in almost every category, we beat budget.
So in 19, we did have a very favorable modified cost per adjusted admission calculation. The year before that, we were just shy of target. So I think, and then, 2 years ago, we used a different metric. We've used disrupt dollars achieved. We've,
FTEs per adjusted patient day.
we did, yes,
I mean,
because it's driving
To me,
50.
that's one of the variables that really ought to be in the calculation, because it excludes the single variable of budget versus actual. And it really puts it down to, once we know what our FTEs per adjusted patient day are, that's real dollars. That is real expense, and it's very measurable. And so I have a little bit difficulty, because I think this particular metric becomes a bit generic and a little obtuse compared to some of the more specific metrics that we know are going to result in savings.
So the FTEs per APD calculation, I would say, is kind of incorporated within here. And that FTE goal is based on a very similar threshold being budgeted, target, and stretch. There's not going to be one perfect metric for the financial goal outside of bottom line, how do we do? But, and that is the trigger. We do make sure we can pay for the plan. But when you try to find one operational goal that is hospital-wide for inpatient, outpatient, ancillary support services, you do kind of come back to this. And it is a industry-recognized calculation, the adjusted and cost per adjusted admission. So I don't know, I hear what you're saying, but I think that the FTE per APD is a much more narrow calculation than this one is.
For sure.
It also does not account for the dollars spent on your budgeted FTEs. We could have a staffing mix change that would cost us more or less, but we're measuring worked hours and paid hours versus what it cost us for those hours. So, kind of really the bottom line is going to be the dollars, and how are we carving out some of those expenses that we incur for patient care across the board. And this is the one all-in calculation.
I mentioned this to Sharon before the meeting, is I'm totally lost in the mathematics here. I don't know what it means, or how you get to it.
So conceptually, it's not intuitive, but it's really not that difficult once you break it down. An adjusted admission converts revenue into an inpatient count. Because our outpatient, inpatients get admitted. And we know our inpatient revenue, we divide that with our admissions. And that might be $25,000 worth of revenue for one inpatient. Then we take our total outpatient, which is pharmacy doses, it could be an MRI of the head, it could be an ED visit, it could be an outpatient surgery. It could span from a couple of dollars to $10,000. We take that average $25,000 in my example, and we divide our total outpatient revenue, and that gives us the dollars, the number of outpatients that produce the same amount as an inpatient case. So that's how we convert outpatient volume to one number and add it to inpatient. So I don't know if I made that better or worse for you.
Well, let me ask it another way.
Surgeons are not intuitive. Okay? Just remember that.
Could we, because we always come back to actual, even though you budgeted last year on budget, we were so much less than budget. So how can we show we are doing better? Because when I look at this, I can't see a positive there. it looks like to me, and this is just starting, when I look at this, it's saying that our modified cost per admission is going to increase somewhere between $800 to $1,025. That's what that says to me. And
And-
I don't think in our wildest dream that's going to happen.
We will have an increase.
You
What
will
this
have an
number
increase.
does not show is the associated revenues that might be coming in with those increased initiatives and expenses. So, in the smaller group, we kind of went through
Yeah.
what might be accounting for that $1,000 increase. $350 of that increase is related to that 22 million operating improvement fund that we have in the budget for onboarding projects. We have another $310 per adjusted admission for increased salaries for the assumption that we will not be under budget in FTEs per APD, but will actually fill those positions. We added a pretty extensive care management initiative this year. We also had some patient safety. We had markets and merit, so that normalized inflation is included in that 310. The co-location of the data center, the PACS conversion, and some of the presumptive screening, the purchase services went up there, and that's $65 per admission again. And then the rest of them are under $4 million in total, and, you know, closer to $60 and under. But there's some really large initiatives that we have in our budget that are driving that increase from 19 to 20.
And we didn't have any of those costs, we didn't have any increases from 18 to 19 and from 17 to 18. Because all I don't understand it. I mean, I understand what you were saying. It's just that if I'm a constituent looking at this, the optics still doesn't look good.
Our cost per admissions have increased from 17 to 18 to 19. So it may not be the full impact that we have in the 2020 budget, but they do increase every year.
Yeah, we had an increase, and from the first time, it was $12,765 to this one, $12,995. So you haven't seen that kind of increase in the actual. That's all I'm saying. I know you're gonna have an increase. I just don't think that budgeted increase is gonna be that high. And when you compare it to actual, I don't think it's gonna be close. That's all I'm saying. It haven't been passed, and so that's how I see it. And Sharon and I have been working on this, and we've been trying to figure out a better way to look at it, and so I hear you, Trent, so.
I just don't think it's a qualitative measure. I think it's a quantitative measure. And I
Okay.
think to the extent that we're trying to equate our incentive program to performance, then this is not a qualitative measure. This is a quantitative measure. And I think there's better measures that we could use. I'm not thrilled with that measure.
So what my challenge, I can't see the impact that we do on the ambulatory side as a system, like the impact and lower the cost of treating the patient, because you don't want, you're trying to avoid hospital admission as much as possible, because the cost is going up high.
Sure.
And what are other outlets that we can bring the cost down? I just don't see it. Like, for instance, you can't discharge patients, especially behavioral health, if you don't have a place for them to go. So do we keep them here at a high cost, or do we invest in a residential or something? I just don't see how we address the lower the cost by looking at that. So that's my challenge. I don't see it going up.
So could I offer that maybe you and I, and we kind of get some information from Trent and them to see if we can come up with more of a measurement that would be better? With that, would you be agreeable to go back and we look at that? And even if it has to separate inpatient from outpatient, some kind of way, so you're doing a good job, but if I look at this, I don't see it. That's all I'm saying. I would like to be able to have a performance measure that you show that improvement?
So part of any measurement is going to be, at least for threshold in my mind, it has to be based on what was approved in the 2020 budget. We can move forward and use a different metric, or we would, I've got 350 directors that are working towards a 2020 budget that's already been approved, and we've kind of sliced and diced that up so everyone has purview to their budget. If we move threshold off of budget, I would have to go back and replan with each one of those directors and try to make sure that our budget ties back to that threshold in order to have assurance that we would meet it.
Could we just look at, maybe
Sure.
this is not the best measurement for us? Could we just think about another measurement and see if we could look at it that way?
Yes, I can.
Your budget is
ask
already
around
done,
and-
not asking you to
yes.
go back and redo budget.
No,
but,
I'm just
yeah.
saying, as we move forward and looking at different metrics, in my mind, a financial metric does have to be tied somehow back to our approved budget. If it's not, then each director may not understand what they have to achieve to get the full organization back to threshold. So I'll have to.
Well, I guess I'll ask it this way. All of these other matrix, those folks have budgets that they've got to stay within and come within too. They aren't going to be able to do what they need to do if they get way out of budget too. So I think budget-wise, I'm okay with knowing we have a budget. But if you have a measurement that if we're going to come back to actual, somehow I kind of need to see something that ties that into the next one. And so I'm with Trent. As I said in another meeting, I don't know if this is the right measurement. I don't know the right measurement. I'm just having problems with this one.
I realize you can't go back and change threshold. That's static. You can change target.
We can. Now, in our original discussions with a smaller group, we had proposed, similarly to last year, a 0.3% reduction and a 0.5% reduction for stretch. We've increased that reach. So target is 0.5 and stretch is a full percentage now. So we've doubled that expense decrease, and that represents close to $10 million on stretch that we would pull out of expense.
So how does that, so equate that back to the FY19 result, Sharon?
So the 19 result, so for dollar savings, last year was 3 and 5 million. This year, it's 5 and 10 million.
So would it make sense to have,
For target stretch.
so is it that you are talking about your savings that you're going to have?
Yes,
That's
so
3 to
in
5.
order for us to achieve that target that's on the screen and the stretch that's on the screen, respectively, that would be a $5 and a $10 million cost reduction from our budgeted amount, if that's what Trent was asking. Last year, it was closer to a $3 and a $5 million savings for those two numbers.
If you were going to put your
So we've doubled our stretch from
3
last
to
year.
5 million last year, okay?
Yes.
That's what you said. So your threshold this year is what kind of saving? Would it be?
5 million, it was our stretch goal from last year as a percent. So we have effectively doubled the stretch from last year, and the target this year was the stretch savings last year.
I understand it. I completely get it. I don't think it's the best measure. I think it's too quantitative. I don't think it really gives us a lot of qualitative evidence. I'll go along with it. I just want to say that I think we can do better.
Yes.
Let me say
Zim.
this, probably we on the board weren't as diligent when this was presented to us in the beginning to question what you were doing. So what I'd like to propose is that we accept this as it is, but then make up what it ought to be based on our conversations and what you think, and just set that one aside and dummy that one, okay? To see how it you would have come out otherwise. But I think what I hear you saying, and I tend to agree with, is that ship has sailed for this year, and it would be a lot of work to go back and do something different. So let's not do that, but let's sit down and make up a plan that would have been more optically friendly, and let's track it along with this one during this year.
So at the next HR committee, I can definitely visit with, I might pick DT's brain and see if he has seen a stewardship goal that would be more appropriate. I'll also reach out to a few of my colleagues to see how they measure from company-wide. And we can have that discussion to start planning for 2021 at the next HR committee. And you may or may not like any of those, and we can go back to the drawing board.
Yeah, I kind of agree with them on this, and we're already a third of the way into the fiscal year. And it's going to be at least another month or two before we came up with a new metric. So we would be almost halfway through the year before we gave directors a new direction.
It is.
And
Only 10%, right?
And what I'm saying to you is, let's look at
Yes.
parallel to this one that we're not going to use for the incentive plan, but that will give us some data and confidence when we make up next year's as to what our stretches, thresholds, and everything else ought to be. Okay?
I'll have that for you at the
Yeah.
next HR
Yeah,
committee.
it's just one of those things that when you talk about an incentive plan, I've always said the incentive plan should not be so high a mountain that you can't climb it, but also shouldn't be so little a hill that you can get there without any effort. And so somewhere in between there is what you're targeting to do to make sure that everybody is really understanding what their goals are and understanding that it's going to require diligent effort to get there. Okay?
By its very nature, stewardship, if we're measuring financial performance, it's going to be quantitative. I don't know how you get qualitative out of measuring financial performance.
Well, Steve, I don't agree with that. I don't agree with that, because what we're trying to do as a system is we're trying to move this system to overall improve the quality of care for our patients across the board. So everything that ultimately we do, including saving money, ultimately becomes something that we can translate, hopefully, to improved care for our patients.
Absolutely.
So I think when we measure a number against budget, there's a lot of anomalies that occur in budget. And budget is again, historically, budget is the variable that's used, and I get it. But there are, in healthcare, a lot of other metrics that I think do a better job of tying quality performance to quantitative expenditures. And I think we can find those. I just think this one is not, I don't think it's the best one. And if we say next year, this is the best one, then I'll shut up and not say anything else about it. But
You will not.
But I'll go along, I agree with what Zim said.
Okay.
I really do.
You know, we've discussed every single one of these, and the thing that started going through my mind is, are these even appropriate? Should we be still dealing with these pillars, or should we be looking somewhere else for better data? And
I think that, Mr. Chairman, is a very good comment, because it's possible that we as a board need to get back together and really do some hard thinking about our strategies and pillars moving forward, because it's been a while. I think it's a good point, Chuck, I
Well,
really do.
I think Michael was the one that told me, but I'm not sure, but we've been dealing with these for 10 years.
Yeah,
And
No, it's-
healthcare has changed a great
it certainly has,
deal.
certainly has.
Work that we plan to do over the next year is to bring to you that recommendation, is whether these are the right pillars, and it's probably has stimulated a lot of this conversation, because to your point, this may not be
Yeah,
the
I
right
agree
pillars that we're looking at.
Well, see, I'm gonna speak as sort of
Okay.
chair-elect here.
Go right ahead on.
You're elect.
Yeah, wait a minute, Chair-elect, you're already elected.
You gonna run again?
Charlie is sleeping well yet. But Ralph has mentioned this, other people have mentioned this. I think we need to have, I don't want to say a retreat or pick a term,
I think it's a good term.
but we need to get together as a group and decide where are we going and how we're going to go and how we're going to measure ourselves. That's just,
I think you hear all total agreement in here.
because when all the board members are confused over how we're going to allow employees get some extra money, I mean, I'm lost.
Okay,
And I'm pro-employee, I mean, good Lord. I mean,
yeah. I think we all are. Okay,
so that's the plan, Ralph.
Very tough, because we're moving
Thank
toward
you.
okay.
transformation of health.
But now, you're not putting that on my calendar, right? You're not putting that on my- Are you putting that on my agenda?
He's the chairman, he can do anything. Karen, let me make sure you understand.
Here it is, make it so.
I'd like you to look at, there's several things that have now come out on the floor. One is, do we have the right measurements, which is always something you ought to be looking at. But look at your total block as it is and do some adjusting, paper adjustments, not to what you're going to do. And then the second thing is, and when we say have a retreat, most boards have retreats. What a lot of board members don't recognize is when you have a retreat, there's a lot of work staff has to do to support that. So I think before we go schedule a retreat, I think we need to have some more conversation and make sure that we're not going on a wild horse here. But it's clear, I think you're hearing us say, it's time to be more reflective on how we've been doing business and more proactive in how we do it in the future, okay?
We only have 60 days to do that, otherwise they busy with their budgeting for next year.
Yeah, they've already started probably.
I didn't think he was saying that. What I understood is we were going to keep these measurements
Yeah.
for now.
Let's move
And
on.
then we'll move on this, but at the same time, we're going to be looking at what we're doing. Is that not what you heard us say?
I thought that's what I heard you say, but
Okay.
I'm not gonna put words in your mouth. But to DT's point, Karen and I have had some high-level conversations, but, the overall goal, and it's taken us a few years to perfect this, would be as soon as we get these 2020 goals approved, then immediately begin to work on the 2021, because
Right.
probably around the May timeframe is when we would be layering on any budget initiatives and expenses. That would be the moment that we could really be impactful with goals and visions and how we could start to redirect some of those budgetary funds along with the facility plan. So it's all kind of gonna have to come together in the next 3 to 4 months, and it will, but understood and that your comments I've taken to heart, and I will be trying to find some better metrics or alternatives that we can discuss, and I'll bring several. And, but it is the stewardship for me is very difficult when you look at how the plan is impactful across the organization, to really focus on, what every person can do and still be impactful to reaching this goal.
Okay.
Yeah.
All right. We done with that one? Okay, all right.
If you're
Okay,
done,
thank
done.
you, Sharon. And so next is the physician proposal, which is only one change. Sharon? I mean, Dr. Karen?
Sharon,
Yeah.
Sharon and Karen, y'all get me confused here.
Karen's still here.
Okay,
So the annual incentive plan for, I guess this is for the physician executive.
Yeah.
This was, conversation around this, again, these are the same goals and metrics that we just previously discussed and went through. The only subtraction off of this is compared to the overall annual incentive plan is the stewardship pillar, and there was discussion around that last time as to why that would not be.
And whatever recommendations we've made on the other program that concerning the service, you'll come back on that for this group. Remember, we took the stewardship off of the physicians because of the start, that we didn't want that. So we're okay with this?
And we moved the 10%
Mhm.
to the other one.
We got it in the
We
quality
moved it
service
into the
and people.
quality, yes.
Okay.
Moved it across.
Okay.
Any-
Everyone comfortable with that one?
Any
Okay.
question on that one? Okay, great.
All right.
Our next one is our LTIP, proposed LTIP. This has not changed from our previous FY 2019. Continues for quality to be the Leapfrog Hospital Safety Score and our cost per adjusted patient admission.
Okay.
Any questions around that?
All right.
For those 3 physician executives who are credentialed here at the hospital, again, the same conversation around the Stark law apply to this one. So we will continue with quality, the Leapfrog Hospital Safety Score. And what was added here is physician alignment. This is different than our physician engagement. Physician engagement is much like our employee engagement, which reflects the work environment. So how well they feel supported, would they recommend the hospital? Questions that are very much like those that we take our employees through. Alignment speaks to really the collaboration and the communication between your physicians and your leadership, whether that be your physician executive leadership or other executive leadership. Those questions are a little bit different. Some questions that come through that survey include, I have adequate input into decisions that affect how I practice medicine. I can easily communicate any ideals or concerns that I may have to the executive leadership team. Executive leadership team is responsive to feedback from providers, and I have confidence in the executive team's leadership. So that's just an example of those questions that differ from the engagement.
What was your sample size on that one, Karen?
Pia? How many providers took the survey?
The participation rate was 70.
Yeah, I don't know what the absolute.
I got
number-
it.
yeah, Which was really good, very
Go
good.
through my
The
packet.
previous year was below 30%, so considerable improvement. So we feel that both of those are important. It's not only engagement, also how well they align as we work with our claim physician group.
Okay. Any questions or anything on that? Okay. All right. So we need this, now that we've had our full discussion on that with the recommendations, I will need a motion to approve with the recommendations, okay? For the-
Move to approve with the recommendation.
All right.
Second.
All right, is moved by Zim, second by Chuck. All those in favor signify by saying aye.
Aye.
Any nays? Okay.
Thank you.
Staff said nay.
Thank you.
Okay. All right. So now, that will conclude our open meeting. We need to go into closed session, so now.
Let's do. This
We've done this
There's
one. Oh, okay. Wait a minute. So you're saying I need to do the annual and the long-term as separate? Okay, I'm sorry. Okay. Okay, we just approved the annual incentive plan goal. Now we need a motion to approve the long-term incentive goal plans with recommendations. Okay? Zim, Roger. Okay, all those in favor signify by saying aye. All right. Now, we will need to close to go into closed session. And we don't need but about a 5-minute break, gang. It shouldn't be long, I swear. I said this one would be long. Thank y'all. That was a good discussion. Yeah.